Good afternoon, everyone, and welcome to this session. Today, our session carries a somewhat provocative title, Is Mortality Dead? Think about that. Is mortality dead? The ambition to treat aging not as an inevitability, but as a solvable medical condition has shifted from science fiction to mainstream biology. In 2024 alone, longevity-related biotech drew over $8 billion in funding. Today, we'll explore the convergence of biology, venture capital, and healthcare innovation, and what happens when the human lifespan itself becomes an investable frontier. We're joined by three leaders who represent the science, the capital, and the ecosystem creation behind this new age of biotech. Jake Becraft, a synthetic biologist and CEO of Strand Therapeutics. Josh Fink, founder and managing member of Luma Group. And Karen Heidelberger, partner and chief partnerships officer at Deerfield Management. Now I'd like to ask our esteemed panelists to briefly introduce themselves and their companies. Why don't we start with you, Karen?
Sure. Thank you very much, and appreciate being here, and thank you all for coming here today. I know what you found, but FII has been pretty amazing for me, so I'm really happy to be here and be back in the region. Karen Heidelberger, I am a partner and chief partnership officer at Deerfield Management. Deerfield is one of the largest US-based healthcare investment firms. We invest all across the healthcare ecosystem, from therapeutics to medical technologies to healthcare services and AI. We have really spent the past 20 years building up infrastructure within Deerfield so that we can not only be an investor, but also a very supportive partner of all of the companies that we invest in. We do things as early as taking science out of the academic institutions to trading in the public markets. So we really have a full suite of everything that we do.
Thank you. I'm Josh Fink. I'm the founder of Luma Group. I first wanted to thank everyone here, thank FII, and thank the Kingdom of Saudi Arabia for putting on such an extraordinary event. I'm the founder of Luma Group. Luma Group focuses on science and on taking cutting-edge science and translating that into best-in-class novel therapeutics, diagnostics, and devices. And our North Star as we do this is to improve human health outcomes, to improve longevity, to improve health spans. I believe the beauty in doing so is in doing well for humanity, there's also a great business opportunity to disrupt healthcare, which is 20% of US GDP, 12% of global GDP. And so that is our mission, and it's a very fulfilling one.
Jake Becraft, CEO and co-founder of Strand Therapeutics. We're a next-generation genetic medicines company. In much the same philosophy as Josh's investment group focuses, our thought on medicine and the future of medicine is that biology is inherently programmable, biology is inherently accessible. And so right now we are sitting on the back end of a decade of some of the most explosive biomedical and genetic medicine research ever. We have all sorts of CRISPR, Cas9, new types of editing technologies, cell therapies. All of these great innovations are fundamentally limited at present because we're very much limited in how we get them into cells in the body. How do we deliver CRISPR and gene editors to the correct cells? How do we deliver chimeric antigen receptors to T cells within the body? That is what's going to control the scalability of medicine. And so at Strand, we are really founded around the idea that using AI, synthetic biology, and new technologies around mRNA medicine, we can find ways to deliver these genes directly into the cells, make scalable, accessible, radically improved treatments for patients both within the United States, where we're based, and globally.
Thank you very much. I'm HP Goldfield, the moderator, so let's start from the top. The first subject will be the economics and ethics of immortality. As investors begin to try to price the value of longer life, what are the true risks of this emerging asset class? Josh?
I think we've only begun to scratch the tip of the surface as it relates to the risks of much longer lifespans. In no particular order, as we think about retirement and retirement savings, we already have a massive funding gap, an underfunded gap with both the public savings pools, the private savings pools, and the household savings pools. If people are going to live substantially longer, how are they going to pay for it simplistically? We've not thought about that. We've not done the financial planning for that. Second, if people are going to live much longer, if we're going to eradicate many different chronic and acute diseases, we still have not been able to solve diseases of longevity, Alzheimer's, neuropsychiatric disorders, dementia. These will eventually inflict everyone. And sadly, our understanding of the brain is less than 1%. We are nowhere in terms of being able to attack these diseases. And I'd say lastly, as it relates to the population, I think it's very important so that we don't have a increasingly stratified world between the haves and the have-nots, is to put access front and center. As we all work to develop novel therapeutics, as we all work to extend health spans and lifespans, I think it is very important that these cutting-edge therapies and diagnostics are done as quickly and as cheaply as possible so that people less fortunate around the world have access. So this care can go to people without socialized medical systems, that socialized medical systems themselves can afford to have this cutting-edge care, and that less fortunate countries around the world can deliver this care as well. I think this is very fundamental, or else we're going to enter a world where the haves and the have-nots will be exponentially greater than today, and we might even have conflict over access to healthcare, and this is a world we don't want. And I'd say last but not least, it is the importance as we live longer to maintain these social bonds between families, social bonds between societies. I think if you look through the span of human history, we've not thought about what it actually means to live to 125 or 150, what it means for the family unit, what it means for the individual in his or her relationship with society. And I think there'll have to be a whole new rethink of how society functions and an individual's role within society.
Thank you. Karen, how does Deerfield think about this question?
Well, I think you brought up a very interesting point. There's a great difference between health span and lifespan. And, I think from Deerfield's perspective, lifespan is not necessarily what our goals should be. It should be health span. I don't want to be 130 with all my compatriots gone and my children in their 80s perhaps dead. So how do we actually think about approaching this issue from a way that makes sense for us as humans, as opposed to just being a brain that can solve a problem, right? Because by solving that one particular problem, you could be creating massive other problems, and you alluded to a lot of what those, or you didn't allude to, you stated what a lot of those problems could be. So from Deerfield's perspective, we are a humanity, and how do we think about this through a very ethical standard so we make sure that, curing cancer is one thing, but perhaps we try to cure cancer and Parkinson's and Alzheimer's all at the same time, so it's a concurrent thing that we're looking at.
Thank you. Jake, what do you perceive to be the ethical and economic consequences to society that may soon have to manage immortality?
Before we get into like a full idea of immortality, I think the big thing is if we have medicines that appreciably affect either health span or lifespan, how will we pay for it as a society? Because right now, in general, the way that medicine is distributed versus age is that most medicine is distributed to people in the last quartile of their life. If we are going to shift people's health span and lifespans longer, we will be distributing medicine to people earlier in their life in order to maintain, prevent deterioration, which will give us massive, massive savings decades down the road. But from a near-term ROI, it is an investment that needs to get made, right? So you asked like how, in the United States, how Medicare and Medicaid, accounting for 25% of global drug revenues, is going to support something. If we look at GLP-1s as a great example of this, there is an incredible amount of evidence that GLP-1 drugs massively decrease all sorts of different mortality, from neuroplasticity all the way down to obviously obesity, diabetes, and other sorts of cardiac risks that come along with those drugs. But if we give GLP-1s to 80% of the population under 45 years old, that's an incredible amount of people. And so how will we grapple with the cost of delayed savings in a system that already feels overtaxed? I've been, this is my third trip to Saudi Arabia. I am incredibly envious of the leadership and sort of way that the kingdom is thinking about healthcare and investing in it. I think right now the United States represents 50% of all global drug revenues, and the United States has to lead in order for the ROI to make sense for investment. And so really we have to build a new framework over what does it mean to have less sick elderly people, but it means we have to pay it today, at a time when we have more elderly people than we've ever had in our entire history as a country. And so that to me is the biggest existential threat. How are we going to pay for it today?
So can I just bring up one point?
Sure.
And that, at least within the United States, we have the patent system, which, it takes 10 years to get a drug to market, which means you have 7 years essentially left of patent exclusivity. After patent exclusivity, the price drops to near free. So I agree that we have a problem in the short term, but how long and how big is this actual problem when we think about the lifetime of a drug and we give it out? So it seems to me that for each new cure that we have, and let's think about cures, not treatments, you're going to have a temporary blip of cost where people will shift to that drug, and everything else thereafter, all those patients thereafter should pay almost nothing for these drugs. So I think that you have an expense when you have a new drug that ultimately goes away. So there is a way that we can actually continue to do this. And I think our system for this actually works really pretty well. Now, whether or not there's global responsibility for this, that's a whole different question that I don't know.
Let me.
I think just to add one thing, as we think about longevity, all of our businesses are focusing on coming up with novel therapeutics to completely cure and eradicate disease. But I think what needs to be said, and it goes against what we're doing, is that so many chronic and acute diseases can be solved by lifestyle changes. And we're all guilty of it. But if we all slept more, ate better, exercised more, had less stress, we would have massively less acute and chronic disease. And I think there needs to be, around governments around the world, material efforts for young people in school to instill the right habits in them, to instill the right norms and right things in terms of their eating and sleep and stress management and exercise. This would make a dramatic difference at zero cost, well, actually a huge savings for society.
One question I have to follow up concerns access. And, how do we ensure that when there are major breakthroughs in science, that there is, access by more than the elites or the funders or the major billionaires? How do we just ensure that mortality doesn't become a deadly conflict?
I'll answer this first because this is actually the focus of why we started Strand, right? Is how can you make medicine more scalable? I think if we look at like CAR T therapy, chimeric antigen receptor T cell therapy, and we look at just the United States right now, it's an incredibly inaccessible therapy. In fact, where I grew up in central Illinois, you can't get CAR T therapy for less than a 5-hour drive. And so if you're a sick patient, you don't have access to that medicine. You live in one of the richest countries in the history of the world. You live in this area and you can't access that medicine. Before we even talk about how are we also going to scale this medicine out to the global, to the rest of society, very wealthy nations will be able to access it. Very wealthy cities will be able to build states. We have to think about what makes a drug great. What makes a drug great is solving a disease and being able to be scalable. That's what makes it great by measure of how many patients it's able to access, and it's what makes it great to investors to put an ROI in, because the ultimate profitability of your investment will be dependent on how many people can you access and what is the unit cost per drug that you put forward. Some of the drugs that we've made in the last 10 years represent massive technological breakthroughs, and they are awful drugs when it comes to actual profitability, yet they are incredibly expensive to the consumer. People are barely winning, right, in this state. Very, very sick people are being able to survive, but more numbers of that are dying because they can't access these drugs simply for a infrastructural-based piece. This isn't greed. This is the inscalability of the first medicines we made. How do we fix that? We focus on the problem. I think every great entrepreneur I've ever met in my life says, how do you fix a problem? You focus on it. We have for so long treated advanced cell and gene therapy the same way we treated small molecules, which was let's brute force it to get enough patients to prove that this has efficacy, and then the rest of it will be solvable. CAR T therapies, CRISPR, the current commercial CRISPR therapy, a number of the gene and cell therapies that have been approved in the last 10 years prove to us that that thesis is false when it comes to these more effective, more complicated mechanisms. And so as an industry and as investors within this industry, we have to focus on essentially building infrastructure of medicine. How do we think about building great drugs in the world of scalability, access, and efficacy? We can build it. We can do it. The technology exists. But if we continue throwing more money down the pathway of the next fancy mechanism and not enough into how that fancy mechanism gets to 10,000, 100,000, 100 million patients, we're never going to get there.
So
I think the most analytically obvious and front and center thing to increase access and bring down the costs is our system and how messed up the system itself is. Why do the PBMs exist? Taking all this margin, increasing the cost of approved drugs for the consumer, for those in need. This is a shame. Washington needs to do something to eliminate the PBMs. Pharmaceutical companies should be able to sell through pharmacies direct to the consumer. Second, the FDA process, getting regulatory approval. We are having a renaissance in biology. This is being sped up by AI, making this renaissance cheaper, faster, better. Yet, you have to go through human trials, you have to go through the FDA process. This process is expanded massively in terms of time, in terms of costs, in terms of inefficiencies, and frankly, waste, fraud, and abuse. This completely needs to be rethunk because all of these new novel therapies and diagnostics we're coming up with, it shouldn't take so long to be approved. It shouldn't take so long and so much money to get to patients. It's a real shame, it's a real problem, and it needs to be addressed now. And this would be one of the biggest ways to solve access.
Thank you.
So I mean, I just think 2 points here. You know, number one, America's system, as we know, is broken, but I'm really hopeful that there are many other societies out there where they do in fact have a one-payer system where this distribution issue and the lack of access is not nearly as prevalent as it is in the United States. Now, a lot of those other regions discuss what is the value of a life, but it's a decision that is made as to how people are going to receive the drug as opposed to access and whether or not they can get to it. And the second point, I forgot what you said and I just lost my second point, so forget it.
Okay. Another question that comes to my mind is the solution to aging, to longevity, really the fountain of youth that Ponce de Leon centuries ago went searching for in Florida? Or is it a solution that's going to be achieved by looking at analyzing it, the problem, the issue of longevity, tissue by tissue, cell by cell, organ by organ? Is it a pill or is it a much more complicated solution?
It's a cornucopia. It's arrows in a quiver that sort of, you know, in the near term, whack-a-mole out the diseases that are indicative of aging. In the longer term, you know, you have broadly applicable, GLP-1 drugs are a great example of this. Next generation versions will be a great example of this. Ones that have, you know, treat core early issues that can then be expanded over time. But I think that as we wheel back and we think about what should be our goal, I believe in healthspan and lifespan extension, but healthspan's got to be first. I don't want to add years beyond 80, beyond 90, beyond 100 if my quality of life, my mobility begins falling off rapidly at 60 and declines. You know, I don't want to be 120 years old right now if I'm continuing on this negative piece. So healthspan first. 80 amazing, mobile, healthy, active years. Then let's talk about adding more years onto the back of that. Then that will inevitably drag lifespan forward. That is what I think is going to really change the way we think about life.
How much, switching gears a little bit, because we only have 30 seconds, so quick answers, folks. How much will AI drive the answers?
Massively.
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 I was going to say the same thing.
Massively. It will take time. It will take time and efforts because biology itself doesn't speak human language and is inherently unstructured. So for the traditional LLMs difficult, but it will revolutionize everything from drug discovery to drug development to doctor-patient interface, everything.
And it's changing the clinical trial
And
problem,
absolutely.
right? It's going to shorten that extensively.
Absolutely.
So this is going to
Make it
become
cheaper, faster, better.
right.
Like
flywheel.
everything with AI and how it's been so far, it's very suddenly and then all at once.
Yep.
Well, I have about 6 more hours of questions that I didn't get to, but I think this is I was told we're timed out. So I just want to thank my panel members for such a lively, interesting, and compelling discussion. Truly.
Thank
we
you.
need more time,
Thank
so
you
to
so
speak.
much.